Hey, so if you were taught the way I and everybody else I know was taught, you was told to get as much information as you could possibly get before making any sort of conclusion or decision. Clinically, this means asking as many questions as you can think of and do as many tests as you possess before coming to a decision on the diagnosis, the treatment planning, etiology, or prognosis. The problem with this approach is it doesn't work. You get overwhelmed with information and anchoring takes place. Your brain doesn't work that way. Nobody's brain works that way. The people who told you to do this brains don't work that way, and the people who told you to do this do not work that way either. It's an impossible way of working, and you end up getting deeper and deeper into it. This is why the first thing you try to do is shift from that type of approach to pattern recognition, which goes from maximal information to minimal information and tends to be more accurate at the end of all this. So obviously we're talking about script focus, hypothetic, abduction or inference now. And there's a mantra that I've probably used on you before, and it's 4 questions, 2 tests. I'm thinking of having t-shirts printed, made with this printed on them. But it can also be misleading. You don't have to ask 4 questions. You can ask 3 questions, 2 questions, 6 questions. And you don't have to do 2 tests. You can do more than that or less than that. The trick is, though, that you want to get the least amount of information that works to make the diagnosis you need, not the maximum amount of information for that purpose. So you also don't have to, as the mantra suggests, ask all the questions first and then do all the tests second after you finish with the questioning. It doesn't work that way neither. You can ask the questions first, do the test second. You can do the test first, ask the question second. You can do some of the questions first and some of the tests second. You can do some of the tests first and some of the questions second. It's mix and match, and what determines how you approach a problem is a hypothesis that you first hold prior to asking more questions or doing more tests. So this presentation is about determining which way to go with your process of making the diagnosis. And what I'm going to use is a number of examples based on symptoms, headache, groin pain, and so on. And we'll look at how each one of those symptoms requires a different approach to the problem than another symptom may do. So here we go. Okay, first symptom, headache. Now, most of the information you get about headache comes from the subjective exam and not the physical exam. And the headache can either be spondylogenic, it could be cervicogenic from VBI, it could be a bleed, it could be migraine. There's a whole host of things it can be. And no amount of examining the neck will tell you, actually sometimes whether it's even coming from the neck or what the source of the pain is in the neck. So the history becomes first. Now the problem is that this is referred pain. If it is spondylogenic, then it's referred pain. Now referred pain typically comes on when the local pain is intense or the local pain has been going on for long enough that it then starts to refer. So you can mess around with the neck all you want, doing PAs and everything else, and it may well not reproduce a headache until later on that day. So there's no guarantee at all that examining the neck will actually produce pain, even when the headache is coming from the neck joints themselves. So the objective exam is not particularly useful here. The subjective exam, on the other hand, is. We know what the essential illness script for a spondylogenic headache is. We know what they are for intracranial bleeds, for migraines and so on. So in this case, 70% or 80% of your diagnosis will come from the subjective exam, and very little of it will come from the objective exam. And most of your exam on the neck to localize it is exactly that, not to make the diagnosis, but to refine the diagnosis and to localize it. So in this case, an objective exam for a patient with headaches is not particularly useful. So your entry to making this diagnosis will be from the subjective exam and not from the physical exam. Unilateral low back pain, and this applies to central low back pain as well, has a large number of causes, and testing each cause is going to be very time consuming, and it's not going to be very useful to you. If somebody has pain bending forwards and bending backwards, then what can you say? This could be a disc herniation, it could be a disc plus central stenosis, it could be just a severely painful atypical segmental dysfunction. There's a number of things this can be. So doing a single test is going to help. So you end up doing a bunch of tests based on a hypothesis that may or may not be correct, and you do more tests than you ask questions in that case, and testing takes a lot more time than asking questions does. Also, it's probably going to be less clear cut than you would like. So, but on the other hand, we can take a history. We know the illness script is, the essential illness script is for segmental dysfunction, what it is for disc herniation, for stenosis, lateral and central stenosis, what it is for a fracture, and so on. So in this case, taking a history prior to doing the majority of the tests or any of the tests is much more important than doing the tests first. So there's a good reason not to jump into testing. This is much the same as headache was. You get most of your information from the history, and you refine that diagnosis made from the history, or the hypothesis made from the history, into a diagnosis and in the objective testing. So it confirms the hypothesis you already have from the history, not the other way around. So in this case, low back pain, the tendency would be to ask the questions first and then do the tests. Anterior chest pain is the quintessential example of doing physical testing over subjective testing. If you remember the Vancouver cardiac rule and the cardiac decision rule, palpation was a huge part of those two things. In the Vancouver rule, which is the simplest of them all, apart from the other aspects of this, you only need two things to refer this back to the physician. One is the patient is over 55, and the other is the palpation of the structures reachable being negative, it goes to the emergency room for further cardiac testing. Simple as that. So palpation becomes your premium tool here. You can see that they're over 55, and you palpate the ribs, the sternum, the costochondral junction, some intercostal muscles. If all of those are negative, then it's a reasonable assumption that the problem lies outside of those tissues, and it's got to be within. Maybe cardiac, may not be cardiac. This could be a pleural adhesion, a pleural tear, and you're not able to palpate that. And even though movements, range of motion is painful with pleural problems, your palpation is all negative. So all of that, regardless of the patient's age now, that patient will either go to the emergency room or back to the physician, whichever you think is most appropriate. So this is very much a case of physical testing dominating the subjective tests. So groin pain. There are many causes of groin pain, from sacroiliac joint referral, lumbar spine and low thoracic referral, the hip joint itself, osteitis pubis, visceral reference, and the list does go on from there. But there are a number of causes of this. And the musculoskeletal causes of this, spinal reference, hip joint and so on, really don't sort of all behave in much the same way. Flexion or extension or both bother it, walking bothers it, running bothers it, sitting can bother it, and so on. So asking questions to find out the musculoskeletal issue may not be very useful to you. As far as reference is concerned, if this is organ reference, the viscera itself, then the quality of the pain will give it to you. You're going to get viscerogenic pain. However, if it's the lining of the organ, then it's going to give you more musculoskeletal type pain. And again, if this is what's happening, taking a history as to what bothers it, what doesn't bother it, may not be particularly useful, because when you're moving, the organs are moving, and that's stressing the organ lining as well. So taking the history first may not be the best way of doing this, and it can be confusing. You'll go through a whole bunch of different hypotheses before you hit the right one, and if you're not careful with these and you don't basically truly discard the previous hospital hypothesis been refuted, you'll keep bringing that back into the mix. So this can be problematic. And pattern recognition doesn't work terribly well here at all. They point to the groin and say that's where the pain is. Now, if we go on the physical testing route, then you've got to generate a hypothesis based on what's underlying the pain. The first thing we can do is sort of get rid of the idea of referral pain from the spine by doing PAs up and down the spine. Now, if they're all negative locally, then the chances are the spine is not involved in this pain at all. The problem you've got here is doing PAs over the spine will not likely reproduce the groin pain, as we talked about with headaches. Referred pain tends to come on after the pain in the local area gets worse and worse and worse, or sometime after that's been irritated by an examination. So they may feel the groin pain later in the day rather than at the time you're doing these tests. For the SI joint, Fordin's isn't very useful to us, Fordin's subjective test, because the pain's in the front and not in the back. But palpation of the SI joint may well be positive, and for the most part it will be. Objective testing of the sacroiliac joint, rubbing in the sacral sulcus, is likely to be tender, but again it's not likely to reproduce the anterior groin pain. It is possible to palpate the anterior surface of the SI joint. It's not a very comfortable palpation. And the problem is you're going through structures that in themselves could be tender, the muscles around there, the psoas bursa and so on. You're going to go through them. So if they're the cause of the pain, they're going to be tender on palpation. You really may not know what the hell you're palpating. If you're thinking this is coming from the hip, then do quadrant testing on the hip. This is a very sensitive test, particularly for pain. And if this is reproducing that pain, that groin pain, that's local pain really now, it's not referred. This is local pain from the hip, then you'll get that groin pain reproduced. Hernias, again, they can be more painful on physical effort than they are in resting position. So are you capably to palpate the bulging of a hernia when the patient coughs? I've had a couple like this. I haven't felt anything, but every other diagnosis has been excluded from my standpoint anyway. I've referred it back to the physician and they felt the bulge when they tested it, which is a perfectly reasonable thing. This is what they do a number of times a week. This is what I do twice in a career. So this time it's all about exclusion, but you exclude it through physical testing. So in this case, physical testing, objective testing, is more important than subjective testing. And it's much more efficient and it's less confusing. So I would get these physical tests done first and then follow it up with histories. Now remember, if your physical test is positive, doesn't mean to say you can say there's nothing else going on. If the hip joint's in trouble, the SI joint may well be in trouble. So the fact that I found quadrant testing positive and it's reproduced that pain, it still may be the SI joint, and then the history comes into it a little bit more. So you can mix and match, but most of this is going to be dominated by physical testing rather than subjective testing. Okay, so dizziness. Now we'll use type 1 dizziness, vertigo, as an example. Type 2 dizziness is a bit more difficult to work your way through, but let's look at vertigo. Now, the patient is coming in with neck pain. This is the only reason we're seeing a manual therapist. This is not specific to vestibular testing and vestibular treatment, although the same principles are involved. If they're coming in with neck pain, particularly if they're coming with neck pain and headache and dizziness, then your big concern is to basically eliminate the idea that VBI could be causing this. So with that in mind, a neurological exam probably isn't the worst idea in the world. So we can do a cranial nerve exam. So we start off with a physical test. From there, provided we're not finding neurological signs on that cranial nerve exam, we can then try to determine whether this is a central or a peripheral dizziness by asking, is it about its persistence, its consistency in the direction of rotation, and so on. We can also look at their eyes for nystagmus. So again, we've gone from an objective test to a subjective test. Looking at the eyes for nystagmus, we've moved into a objective test again. We can then think about coupling and decoupling symptoms, which is subjective. Okay, and then finally, any other objective test we need to do from that point on, we can either do or not do. We can refer them out without doing further testing, or we can do more testing with them. So this is very much a mixture of both. But the main thing is, if there's any risk to the patient's health or life, then don't start moving the neck around. This would apply to a sudden onset of severe pain from a traumatic event. You're worried about a fracture, don't go moving the neck around. So take the history and then do the physical test if it's deemed safe to do so. This is a mixture of this. This is both objective and subjective test mixed in together, because this is the best way of doing it. Okay, to summarize what we've said, it can be said in one sentence: context is key. The context being the hypothesis, and that sets the platform for where you go to. For example, if I have a patient from a motor vehicle accident who is complaining of severe central neck pain, then the last thing I'm going to do with this person is look at range of motion testing. It's dangerous, apart from anything else. So your physical testing will be delayed a considerable while and may never occur at all. If I then say, okay, how sudden was the onset from the trauma? It was an immediate onset, and this is as bad as the pain has ever been. Then I'm thinking, okay, this needs to be go to the emergency room. If I'm particularly feeling daring that day, I may palpate lightly for central tenderness, but it's not necessary. Those two factors, an immediate onset of severe pain, and the pain is really severe, and it come on at the time of the accident, whether or not there's a deformity. If there's a deformity, that's just icing on the cake. All of that goes to the emergency room in an ambulance with no further testing. On the other hand, I have a patient come in with lateral shoulder pain, deltoid pain, and this is all going to be about questioning. Now, can you move your arm? Okay, if you can, then it's probably referred. If you can't, then it's probably local. What caused it? Is it coming on in stages? How long have you had this? You've had this for 2 months. Okay, is it getting worse? Is it staying about the same? What's it doing? So generally speaking, you can almost make your diagnosis before finishing the subjective exam, and then the objective exam really just confirms the diagnosis and refines it. However, this is not a straight line process. Your hypothesis may change a number of times during your examination process as more information comes to light and refutes the previous one, in which case the next hypothesis may require you to do a test immediately or ask more questions. So there is no formulaic approach to doing your examination, regardless of what you've been told. You don't take the history first and then do the test, because not every patient that's appropriate for. So you have to do some thinking before you actually start doing the testing, subjective and objective testing. What's the approach with this hypothesis? And I think this is a big thing. The hypothesis is what's important. You're going to base your examination process on each hypothesis as it changes. So I hope this helps. It makes the examination actually less complicated in the long run, but it does take a little bit of thought before you actually start the process. Okay, talk to you in a bit. Bye, everybody.